part 2, which we'll take a look at other causes of epilepsy. First of all, neoplasia. This 39-year-old male with 2 5-minute episodes of staring. We obtained an MRI, and on the axial T2 weighted images, there is some abnormal signal and heterogeneity within the anterior medial right temporal lobe. There seems to be some cystic change in that region, heterogeneous abnormal signal on the flare, and the coronal T2 shows several areas of cystic change in this region. Sagittal T1, some hypointensity, reflecting the cysts. So a heterogeneous mass within the medial temporal lobe. And the primary differential would be between a cortical dysplasia and a DNET, dysembryoplastic neuroepithelial tumor. On these contrast-enhanced scans, the process does not enhance, and neither of those processes or abnormalities enhance. This one turned out to be a cortical dysplasia. This young boy had partial complex seizures, and on the T2 weighted imaging, there is a heterogeneous mass in the more posterior part of the medial temporal lobe. Has some cystic component to it. The flare images show a similar abnormality. T1, heterogeneous hypointensity with some swelling, expansion of that region. And then with the gadolinium enhancement, there is enhancement of this mass. And so, likely some kind of tumor. This is a ganglioglioma. It could also be a ganglioneuroma. Unlikely to be a DNET because the DNETs usually do not enhance. The mixed neuronal glial tumors are commonly found in young patients, teens, 20s, and have a predilection for the temporal lobe. So not uncommon for them to be associated with temporal lobe epilepsy. Large mass in this 45-year-old man with delusional symptoms, a fairly homogeneous mass in the medial temporal lobe, causing considerable mass effect on the temporal horn, and extending into the ambient cistern and compressing the midbrain. Flare images show a similar abnormality. The coronal T1 weighted images show the hypointense mass with herniation of the tumor and the temporal lobe through the incisor of the tentorium. So temporal lobe herniation from the mass effect from this large tumor. With gadolinium, no enhancement of the mass. Large mass, it has the appearance of a glioma, and this is a grade 3 anaplastic astrocytoma. Some of them enhance, some of them don't. It's variable. This is an important entity to recognize it for what it is. There is a cystic lesion in the medial temporal lobe on the flare images. Hypointense on the flare, hyperintense on the T2. So has the features, the imaging features of a cyst. And on the coronal T1 weighted image, it is located right in the choroidal fissure. And this is fairly typical of an arachnoid cyst of the choroidal fissure. These arachnoid cysts are nearly always asymptomatic. This girl did have seizures, but it's very unlikely that this arachnoid cyst is causing the seizures. Nonetheless, if an arachnoid cyst is found in the choroidal fissure, they probably need to be followed for a couple of years to make sure they're not changing. Usually these things are fairly static and do not change over time. If they get very large and the seizures localize to that temporal lobe, then the clinicians and surgeons would have to consider the possibility that it might be causing the seizures. But in most cases, they are asymptomatic. Let's take a look at vascular lesions that can result in seizures. A common entity, cavernous angioma. And on the gradient echo image, you can see the susceptibility effect, the fuzzy margins of this hemorrhage in the medial temporal lobe. On the T1 coronal image, there is hyperintensity in the middle, so there is some residual methemoglobin within the middle of this cavernous angioma. And it's positioned right in the parahippocampal gyrus. If you compare the location to the other side, the amygdala is up here anteriorly, parahippocampal gyrus, and so it's a hemorrhage into the parahippocampal gyrus. This patient presented acutely with bad headache, confusion, lethargy, and the CT scan clearly shows hemorrhage in the region of the temporal lobe and the atrium of the lateral ventricle. There is a cast of blood in the atrium and also within the frontal horn of the right lateral ventricle. A little blood in the left lateral ventricle as well. So an acute presentation, on MRI can see the blood in the temporal horn. It's hypointense on the T2 weighted image due to the deoxyhemoglobin. And on the T1 weighted coronal image, the deoxyhemoglobin is isointense. And there is some periphery of subacute hemorrhage, early subacute hemorrhage representing intracellular methemoglobin. Interesting, on the T2 weighted image, there are hypodensities, discrete hypodensities representing flovoids that have a punctate appearance and also a linear appearance here, probably representing a draining vein. And on the coronal T1 weighted image, again, the hypointensities are the flovoids, the nidus of this AV malformation right in the hippocampus. So what would be the supply to that AVM? Well, likely the arterial supply to the hippocampus. And here on the lateral angiogram, the anterior choroidal artery, somewhere here it's coursing into the choroidal fissure and supplying the nidus of that AVM within the hippocampus. And on the frontal projection, the anterior choroidal artery coursing in the basal cisterns and into the choroidal fissure to the hippocampal AVM. Later image showing a draining vein going into the deep venous system. There was also supply from the posterior circulation, not surprising, because the hippocampus has a dual blood supply from the anterior choroidal and the posterior lateral choroidal artery. Can't specifically identify the feeding artery, but the posterior lateral choroidal artery comes off the ambient segment of the posterior cerebral artery. This patient did not have seizures, but it helps illustrate the vascular supply to the hippocampus. This man had 2 days of visual disturbance and lightheadedness. And on the T2 weighted image, there is an abnormal signal area within the medial right occipital lobe. Also seems to be some abnormal signal in the region of the hippocampus. And that is confirmed on the FLAIR images. Hyperintensity in the region of the visual cortex of the occipital lobe and the hippocampus. And the accessory finding on the FLAIR images is a hyperintensity, linear hyperintensity in the crural cistern of the ambient cisterns, representing a clot in the posterior cerebral artery. And so this patient had an embolus and secondary infarction of the occipital lobe and hippocampus. And looking at that a little more, on the coronal T1 weighted image, there is some hypointensity and swelling of that right hippocampus. And then more clearly seen on the diffusion weighted images, restricted diffusion in the medial occipital lobe and involving the entire hippocampus, the tail, the body, and extending to the head of the hippocampus. So in this case, the predominant supply is from the posterior circulation or the posterior lateral choroidal artery. But again, it has a dual supply, posterior choroidal and anterior choroidal arteries. Infectious and inflammatory disease can also irritate the cortex and induce seizures. A fairly classic case in this 27-year-old man with confusion and lethargy presented acutely to the emergency department. And the T2 weighted images show abnormal signal intensity within the insular cortex, temporal lobe, lateral, anterior, and medial temporal lobe, and then also some of the inferior frontal regions, including the gyrus rectus. Another T2 weighted image. With contrast material, there was no enhancement of the process. There were some linear enhancing structures that we thought were just engorgement of some of the PO veins, but not enhancement of the process within the cortex itself. And this patient has herpes simplex encephalitis, which of course can be a cause of seizures. This girl had a history of epilepsy and was pregnant and was now having several seizures daily. And actually, clinically, they determined that she was in status epilepticus. And the images just illustrate the cortical edema that can occur with status epilepticus. On the T2 weighted image, laterally and medially within the temporal lobe. On a coronal flare image, you can see the abnormal hyperintensity. Also, a little associated hyperintensity within the thalamus, extending to the thalamus. T1 weighted coronal image showing thickening of the temporal lobe cortex, also the insular cortex. And again, this is just a vasogenic edema within the cortex related to the status epilepticus in this young patient. If the seizures are controlled, this will resolve. 27-year-old female with seizure shows a cystic lesion within the left temporal lobe, fairly characteristic of this entity, very well defined. It's no surrounding edema, a little perimeter of hyperintensity, representing the membrane covering this cyst. On the T2 weighted coronal image, high signal intensity. And then with gadolinium, I can see this little structure hanging from the roof of the cyst a little better, representing the scolex of this cysticercosis. No surrounding edema on the flare. The enhanced, sorry, this was a flare image, not a contrast enhanced image, showing the scolex. With gadolinium enhancement, there is some enhancement along the lateral aspect. And so this cysticercosis is probably undergoing some degeneration already. Cysticercosis, of course, can be a source of seizures. Patient was treated with albendazole and dexamethasone to limit the amount of edema. And follow-up images 2 months later now shows some edema around the cyst, because now the wall of the cyst is breaking down and the brain recognizes it as being something foreign. And the flare images illustrate some hyperintensity within the cyst. So this would be the colloidal stage of cysticercosis. And now there's more prominent enhancement around the perimeter of this dying or dead cyst. This woman had lupus and was on chronic immunosuppression, steroids, methotrexate, and so as a setup for infection or reactivation of an infection that she might have lingering within her. And these are all contrast enhanced images, T1 weighted, and they show extensive enhancement of the basal cisterns, sylvian fissures around the midbrain. And there is an abscess within the choroidal fissure that we can identify the location on the coronal images. And the infection is also extended via the Virchow-Robin spaces into the deeper structures within the brain. And this is a patient with tuberculous meningitis. Here's a list of developmental lesions that are often associated with epilepsy. Any developmental lesions that occur during neuronal migration or during cortical organization can be a source of epilepsy. And these conditions such as lissencephaly, pachygyria, polymicrogyria, we saw a case of cortical dysplasia, schizencephaly, gray matter heterotopia, the microcephalies and megalencephalies. And then two of the phacomatoses that would take a look at, tuberous sclerosis and Sturge-Weber, often are associated with seizures. This case illustrates lissencephaly posteriorly, where there's really no sulcation that's evident, this very thick cortex. And then anteriorly, there is some attempt at formation of gyri, and this is more of a pattern of pachygyria. This woman had refractory epilepsy for 30 years. On the T2 weighted images, the sylvian fissure on the right side is open, and it is lined by very thick abnormal cortex. And that abnormal cortex extends into the temporal lobe. On the coronal views, again, that open sylvian fissure and the very thickened aberrant cortex, lining the insular cortex, and then extending into the superior temporal lobe. The associated finding, unrelated, is absence of the septum pellucidum. So this patient has 2 developmental lesions. And the axial image is higher up, showing more of the disordered cortex. Sagittal view showing the multiple small gyri, and also on the coronal T2, you can see the multiple microgyri in this patient with polymicrogyria. Polymicrogyria is commonly found around the sylvian fissure. So if you see abnormal closure, incomplete closure of the fissure with abnormal cortex around the sylvian fissure, the diagnosis of polymicrogyria should be a consideration. This man also had seizures for many years. On the T2 weighted images, there is some lumpy tissue that has gray matter signal along the lateral aspect of the temporal horn. And on the adjacent image, there is a band of abnormal hyperintensity lateral to the temporal horn. On the coronal views, abnormal gray matter lateral to the temporal horn. And of course, there shouldn't be any gray matter tissue lateral to the temporal horn. That should be white matter. And so this is gray matter heterotopia lining the temporal horn. That's likely the cause of the patient's seizures. This 2-year-old girl with seizures has images that are fairly classic for tuberous sclerosis, multiple tubers within the cortex. The one in the left frontal parietal region already has some calcification within it, giving it the hypo intensity. And there are also some nodules along the ventricle. On the gadolinium enhanced image, you can see one of the ependymal lesions. And then on the CT scan, the typical appearance of calcified tubers lining the ventricle along the ependymum. So tuberous sclerosis. And this one, a classic case of Sturge-Weber syndrome, angiomatous resulting in atrophy of the occipital lobe on the right side. And the gradient echo image shows some Peel siderosis, some related hemorrhage in that occipital lobe. And then with contrast, enhancement of the leptomeningeal angiomatosis associated with the Sturge-Weber syndrome. And that covers part 2.